So I thought I would start with giving you a perspective, a global perspective of cardiovascular disease, bring it down to a South Asian perspective, then bring it to the individual level with regards to cardiovascular disease, then speak a little bit about who is at risk of getting cardiovascular disease, and then get into the meat of the presentation, which is in the second half, of what you can do. What can you do about not getting cardiovascular disease? And in particular, what is your responsibility to protect yourself and your family? Because when you protect yourself, you pay attention to your responsibility to other members of your family and your work colleagues and others. Because if something were to happen to you, the impact is on many around you. So it is your responsibility to look after yourself and take care of yourself. So let's stick into the global perspective. If you look at a century ago, cardiovascular disease was the cause of death in about 23% of people, and cancer was the cause of death in about 6%. Over a little over a century, we have doubled the mortality in cardiovascular deaths across the world. And we have increased the cancer death rate by 5 times. Just in 1 century, we have messed up the major health systems in our body, leading to cardiovascular disease and cancer. If you look at cardiovascular disease, it obviously is fairly common in the high-income countries, but it is, in terms of numbers, it is far greater a problem in the low and middle income countries. And by 2030, 80% of the global burden of heart attacks and strokes will be occurring in the developing world, the low and medium income countries. So it's a massive problem, and it's going to be a real issue with the developing countries having to handle this tsunami that's coming. So if you look at the high income countries and you look at the mortality rate over the last 3 decades, it's relatively constant. Farida is hiding that little part where it is beginning to go up lately with her picture. And if you analyze this death rate, you will see that we have basically conquered the maternal mortality and neonatal mortality in the first week or the first month of life. And if you survive that, then you have a life expectancy of about 78, 80 years in the developed world, in the high income countries. Unless you do not take care of yourself and you live an unhealthy lifestyle, then you get the problem in middle age and you become one of the victims of what we call premature death or premature disability related to cardiovascular disease. So if we analyze the cardiovascular death rate in the developing world, in the developed world, so-called developed world, let's call them the high-income countries, the cardiovascular death rate has been dropping significantly. We are conquering this disease very well. And it seemed to have started just when the Makerere University students and graduates moved into the high-income countries, and it has been dropping since. So I'm not sure if it's causally related that those of us who moved into the Western world have contributed to this drop in mortality, but this is what we call a coincidental association and not a causal association. And this is how on the internet, a lot of health data is misrepresented with coincidental or associations that do not have a causal relationship. So us moving to the developed countries did not in its own lead to the drop in cardiovascular mortality. Now, if you analyze this a little bit closer, what's happened in the last decade is we are losing ground. The cardiovascular mortality is beginning to rise again in the high-income countries. And if you look at that, this is data from England and Wales from 1981 to 2000. And it was able to show that the cardiovascular death rate is dropping significantly. There were almost 70,000 less deaths in 2000 than there would have been in 2000 and in 1981. And the improvement in this mortality or improved survival was partly related to better control of risk factors, good lifestyle awareness, public health campaigns, and partly related to the treatments that we have now developed in cardiovascular disease. If you look at this data now in 2020, about 60% of the improvement in survival is due to cardiovascular healthcare, medications and procedures, and 40% related to improvement in lifestyle and risk factor control. But what is happening is during this past decade, we are now having an increase in obesity, diabetes, and inactivity again. And this is now increasing the death rate. And that is beginning to cause a rise in the overall cardiovascular death rate. At the same time, in the high-income countries, the death rate from cancers is increasing. So the overall death rate is relatively constant in the high-income countries, and you will be surprised to know that. But it is because the cardiovascular death rate is dropping and the cancer death rate is rising. Now, if you focus on the low and medium income countries, the death rate from cardiovascular disease is rising rapidly. And because of the high number of populations, the number of people with cardiovascular problems is rising exponentially. And at the same time, the death rate from cancers is rising. So we have a double disaster developing in the low and medium income countries. This was the subject of my keynote presentation that I made in Singapore at the World Heart and Cardiothoracic Conference in September 2018. This amazing problem that we are seeing in the epidemiology of cardiovascular disease and the epidemiology of cancer, and how the treatments of these two conditions is contributing to more problems in the other areas, in each other areas. For example, many cancer treatments, which are highly effective in controlling cancer or curing some cancers, have significant cardiovascular side effects and are now causing an increase in cardiac disease in patients with cancer because they're being treated with therapies that cause cardiovascular disease. So it's a very complex phenomenon that is coming into fruition across the world, particularly in the low and medium income countries. All right, so in these countries, they have a triple problem. They still are dealing with the infectious disease of the cardiovascular system. They have a rising burden of non-communicable ischemic heart disease and cancers, and they do not have the resources to deal with them. So it's a triple whammy for the developing world. This was the primary reason and the construct behind the decision to develop the first tertiary care cardiovascular program at the Aga Khan University in the field of cardiovascular medicine. I was involved in the planning for the 4 years previously, and then the opening of the program in '94, and led the program for the subsequent 4 years. And at the opening, His Highness, the Chancellor of the university, questioned me in front of many dignitaries and the Pakistan media, which was being broadcast on Pakistan television, as to why we went with the cardiovascular program as the first tertiary care program, how it was developed, what is it going to do, what are the quality measures, and various other questions. And probably one of the toughest interviews that I've had in my life, and was the most nervous of them all. This is also the justification for the cardiovascular program development in East Africa. Worked on it for a number of years. developed a strategic plan and authored the document in 2002. And in 2007, when the cardiovascular unit opened in Kenya, it was also part of the oncology center. So it was the cardiac and oncology center in East Africa. So people would think, why did we rush in with cardiovascular disease? These are the reasons behind it. We're preparing for the tsunami that's going to come to sub-Saharan Africa and to Asia. So cardiovascular disease is the number one cause of death across the world in high and low, medium income countries, all of them. The cardiovascular disease prevalence is increasing remarkably in the world, and particularly in the medium and low income countries. The death rate in the high income countries is decreasing, and the cancer death rate is increasing. Whereas in the low and medium income countries, the cardiovascular death rate is increasing and the cancer death rate is increasing as well. So there is this massive burden of cardiovascular and cancer in the developing world. So what's the South Asian perspective? When you look at South Asians, the definition is all those people who have their ancestry in these countries. That's the official definition of who you can call as South Asian. When you look at in the South Asian countries, the prevalence of cardiovascular disease in the rural areas is approximately 3%. That is primarily genetically determined because we have a higher genetic tendency to develop cardiovascular disease. But when you look at the same people with the same genetics who then live in the urban areas, the prevalence of cardiovascular disease rises dramatically to 10%. And over this last 2 decades, since this data was collected, it is even higher than the 10%. The next thing about South Asians is that they seem to want to migrate to other parts of the world over the last 2 to 3 centuries. So we now form 25% of the global population, South Asians do, but South Asians carry 60% of the global cardiovascular burden, disproportionately higher amount of cardiovascular disease in South Asians. So when South Asians move to Canada or to USA, for example, they have a much higher prevalence of cardiovascular disease. And this data is from about 20 years ago. And in the last 20 years, this has increased further due to further westernization of our lifestyle and due to the effects of migration and stress. So we seem to get a lot of cardiovascular disease. We seem to get it at an earlier stage in life. If you look at the proportion of heart attacks in South Asians as opposed to non-South Asians, you will see that 50% of the heart attacks that occur in South Asians occur under the age of 50. So the median is for 50% is the age of 50. The median for non-South Asians is 65. So we get our heart attacks 10 to 15 years earlier than non-South Asians. So if you say, well, I'm looking at median data, if you look at the average or the mean data, which is more recent, shows that the mean age of South Asians getting their first heart attack is 53, whereas non-South Asians is significantly higher at 59. So we get the disease earlier. This is from the Interheart Study. We at AKU were part of the centers that participated in this study that was conducted in 52 countries. And if you concentrate on the mean age of South Asians getting their heart attack, it's 53. And for other countries, it's almost 59 years of age. When South Asians get their cardiovascular disease, they have a poor survival. So whites, when they get cardiovascular disease, they subsequently have decreased survival because of recurrent problems with cardiovascular disease. Indians have less good survival, and Pakistanis have even worse survival. I'm not sure if this is due to the effect of vegetarian versus non-vegetarian diets, or it is due to the relationship of how meat is eaten and how it is cooked uh, in South Asian diets, or whether it is related to stress and personality and an aggressive way of managing life. But all those factors really play a role. So you say, what about us East Africans? This is data from England, and South Asians have a very high mortality when they develop the disease. And if you look at East Africans, they also have a high mortality. But this includes non-Asian East Africans. The non-Asian East Africans have the same mortality rate as the West Africans. So then if you were to look at just the Asian East Africans, it's just as high as South Asians directly, or even higher. So we are not spared, those of us who came through South Africa or East Africa. This slide is probably the most telling slide in the South Asian dilemma of cardiovascular disease. This is a study that was conducted by the National Institute of Health, the premier health organization in the world, and done in the state of California, where data is very well collected. So what we have is the total mortality ratio represented in the green bars, which is at the level of 100. So now we are looking at the proportional death rate in other ethnic groups compared to the total group. So you will see that South Asians over the age of 65 have 1.5 times the mortality of the total group. In the middle age or younger age group, they have 2 times the mortality of the other age group. And if South Asians get the disease under the age of 45, they have 3 times the mortality of the total population. The second thing this slide shows is if you look at the Chinese and the Japanese, they have lower death rates compared to the total population, proportionately, in middle age or in older age. But when you look at this Japanese and the Chinese in younger age, their death rate is rising significantly. And this is the effect of westernization in the younger age group, as opposed to the traditional way of living in the Chinese and Japanese in the older age group. So lifestyle factors play a major role. They accentuate the genetic risk that South Asians already have. More South Asians get coronary disease compared to others, particularly after immigration. South Asians get the disease at an earlier time in life. South Asians who do develop coronary disease have a worse survival, particularly younger that they are. So this is a major problem in the South Asian population. So let's bring this cardiovascular disease down to the individual level. At the individual level, the problem with cardiovascular disease is heart attack and strokes. That is the one major way that death occurs at the individual level, that the person gets a heart attack or a stroke. Or if they do not die, they may develop disability, either physical or a financial burden, and may or may not become dependent, and therefore the quality of life is impacted. So cardiovascular disease can cause these problems that are important to the individual, quality of life or survival, by having heart attacks or stroke. The heart attack or stroke or heart attack can cause a rhythm abnormality, such as ventricular fibrillation or asystole, the heart stops, and that is often the cause of death when you get a heart attack or stroke. So the arrhythmias are the pathway through which you get sudden death with cardiovascular disease. The heart attack could be of a significant uh, magnitude, so that the heart, which is a pump, can get damaged and the heart can no longer pump the blood adequately for what the body's needs are. And that's what we call pump failure or heart failure. So, heart failure is not death, but heart failure is the inability of the heart to function normally as a pump, to pump the blood around the body. So, if you're looking for a good cardiologist, he has to be an excellent plumber to open the blockages or prevent you from getting blockages in your arteries. He has to be an excellent electrician to be able to prevent you from getting these fatal arrhythmias, or if they occur, to instantaneously or immediately treat you. And he has to be able to be a good pump technician to prevent your heart from failing, or if it does fail, to improve the function of the heart. So a good cardiologist is a plumber, electrician, and a pump technician. So on the left side of this slide are the problems that cause a difficulty with your quality of life or with death. For example, heart attacks due to the arteries blocking in the heart, arteries blocking in the brain cause stroke, the arteries blocking in the legs can cause gangrene, amputation. And on the right side are the symptoms that occur in some people who have not necessarily had a heart attack or stroke. And these symptoms are what we call angina or a transient ischemic attack or peripheral arterial claudication. These are symptoms. And sometimes patients have these symptoms, sometimes they have no symptoms, and they may get the heart attack as their first manifestation. So what is this process of hardening of the arteries or atherosclerosis? This is the laying down of cholesterol and fibrous tissue and other material on the inside of the lining of the blood vessel, causing a narrowing in this blood vessel. So this process of atherosclerosis begins in childhood. It progresses steadily throughout life. So it's a disease that begins early, it's progressive, and it often causes no symptoms, and you are unaware of it until a major event occurs, such as a heart attack or stroke. So it is an insidious disease. If you look at children, autopsies of arteries taken from children who have died of other causes between the age of 15 and 24 in this study, you will see that fat is beginning to lay down in the arteries at a very young age, and you're already beginning to develop atherosclerotic lesions in your arteries when in your teenage years or in your youth years. So it's an early start to this disease, and the more overweight you are, the more problem you have with this disease. So overweight children are in trouble, and overweight children become overweight adults. So in the normal situation, blood flows normally through the artery. When you exercise or do any activity, the heart muscle needs more blood, and the arteries dilate because they are soft and malleable, and more blood goes to the heart muscle, and everything works out fine. If you have a narrowing in the artery, it's a rigid blockage with fibrous tissue and cholesterol and other fatty material. And if you do activity and the heart requires more blood and more oxygen, that area of the heart is unable to receive that additional oxygen or blood, and it becomes deficit in oxygen. And that is what leads to what we call angina. So you have increased demand from the heart due to increased activity, or after a meal when the blood supply goes on to the bowel and the heart needs its blood supply, so its arteries have to dilate. But the blockage doesn't allow the increased blood flow to that area of the myocardium or the heart muscle, and because of the blockages. And you get what is called a mismatch between demand and supply. and there is oxygen deficit, and that's what leads to the symptoms of what we call angina pectoris. And in a large number of people, they get this oxygen deficit, but do not feel the symptoms, or the symptoms are so atypical or so vague that they are unaware that this is really related to their heart muscle not getting enough oxygen. So we have this problem of blockages, and the high degree of blockages cause symptoms. The problem of the heart attack is different. The problem of the blockages leading to oxygen deficit is related to atherosclerosis. The problem of the heart attack is different. It's related to atherothrombosis. So you have this blockage full of cholesterol and a thin layer of fibrous tissue on top. The layer of fibrous tissue becomes eroded or ruptures. The cheesy material, which is very thrombogenic, is exposed to the flowing blood, and a clot begins to form and abruptly blocks off the blood supply to that part of the myocardium. So you get an erosion in the plaque, in the fibrous cap, platelets start to adhere and then get activated, and they aggregate formed fibrin strands which trap the red blood cells, and you clot off the artery. So what 2 minutes ago was a 30% or a 40% blockage that you completely were unaware of, was not causing any symptoms, in the next 2 minutes is 100% occluded. It is this abrupt thrombotic occlusion of the artery in an area of a vulnerable plaque that causes the heart attack or a stroke. So it's atherothrombosis, an abrupt occlusion causes the heart attack. Whereas if you have a blockage that's stable and keeps progressing from 90 to from 70 to 90 to 100% blockage, it does not cause a heart attack. You have an angiogram and people say, well, I had one artery totally blocked, two arteries 75% blocked, but he's never had a heart attack. This is a gradual progression of the atherosclerosis, and the heart compensates by providing extra perfusion through the collaterals and what we call natural bypasses, and prevents the area from getting damaged. It's the abrupt occlusion of a small or a minor blockage, the young blockage, which is vulnerable and cheesy, that causes the thrombus. So the vulnerable plaque that causes the heart attack has a lot of cholesterol in it. It has a very thin fibrous cap, and it has this reddish material, which is inflammatory cells. It's a hot, inflamed, hot, cheesy, fatty material with a very thin layer protecting it from the flowing blood. And it often gets eroded by the inflammatory cells producing enzymes, metalloproteinases, that erode this thing and that cause the clot to form and abruptly block off the artery. And this is the very mechanism by which statins work. They prevent you from getting heart attacks or death because they change the consistency of the plaque from a vulnerable plaque to a stable plaque. The cholesterol is much lower in a stable plaque. The inflammation is much less. So statins lower cholesterol one way, and secondly, they act as anti-inflammatories in the plaque and prevent the erosion of the fibrous cap. And the plaque is there, but it doesn't cause a heart attack because it has become stable. Oops, sorry, I dropped my water. Anyway, so the problem arises that you have these minor blockages. You go to see the doctor and he assesses you, sends you for a stress test, and the stress test comes out normal. And you have a situation where you feel you're fine, a false sense of security, and you can still have a heart attack a week or a month later. So you can understand now why people go for checkups, so-called complete checkups, or go and have a stress test and yet end up having a heart attack or a stroke. So almost 50% of the first manifestations of this disease is a heart attack or sudden death. And if you look at all the deaths that occur with this disease, the vast majority of deaths occur before the patient really reaches the hospital or is really begun good treatment within the hospital. So when you look at data in the literature that looks at various clinical trials and stuff, it's only looking at this tip of the iceberg, which is the population that has survived, and not this vast majority of deaths that you are unaware of. The second issue about these deaths is that if you look at all the deaths, so if you look at 100 deaths that occur due to a heart attack, 28% will have occurred within the first hour. 40% will have occurred within the first 4 hours, and almost 50% will have occurred in the first 24 hours, and 60% in the first month. So it is a front-loaded disaster. You often don't have time to do anything about it. So prevention is the key. So if you look at the present day mortality, 30%. People look at mortality data from research papers and they say the hospital mortality of heart attacks is 5% now. No, it is 30% when you take into account all the deaths that occurred before the patients got to the hospital or as soon as they got to the hospital. And 50% of those deaths have occurred at that time. People say, well, my cousin, he was in Nairobi, he had a massive heart attack and he died suddenly and he was completely healthy before and he was taking 2 pounds of garlic every day and he took 7 capsules of omega-3, 6 every day and, all this kind of stuff, but he still died because those therapies are ineffective and he doesn't necessarily have to have had a massive heart attack. Even a small heart attack can cause sudden death because it is the electrical malfunction. Even a small heart attack can set off the electrical abnormality in the cardiac rhythm and give you sudden death. So you don't have to have a massive heart attack to have sudden death. You can have a tiny heart attack and get sudden death. The second issue to know is that when you do have a heart attack or stroke, you have a very high likelihood of getting a stroke or a heart attack in the subsequent 5 years. So if you've had a stroke, you have a high likelihood of getting a heart attack. If you have had a heart attack, you have a high likelihood of getting a stroke because the process and the pathophysiology of these two problems is essentially the same. So who is at risk of getting this cardiovascular disease? And why in 1 century that we have changed our lifestyle and we are now regressing in our evolution? Well, you all know the causes, and I don't have to give you a lecture on that. And these are all lifestyle-related issues that lead to us getting cardiovascular disease. We harm our arteries. What was going to happen at the age of 70 or 80 because of the aging process causing hardening of the arteries has now occurred prematurely at the age of 40 or 50. So you are aging your arteries faster than your age when you indulge in bad lifestyle habits. So it is a complex interplay between genetics and the risk factors. The genetic can play a very little role or a major role, for example, in homozygous hypercholesterolemia, the major cause of the blockage and heart attacks in teenage years or younger than the age of 10 is a genetic mutation. Whereas in most, it is the risk factors that contribute to the atherosclerosis with some degree of genetic contribution. So genetics loads the gun and risk factors pull the trigger. So this is the Interheart study that we participated in from AKU as well, done in 50 countries across the world. And we looked at people who were admitted to the hospital for their first heart attack, as opposed to matched individuals in the hospital at the same time who had not had a heart attack. They were there for a hernia repair or a fractured hip or whatever. And we found in the Interheart Study that those who smoked were the ones who got the heart attacks. So the people who got the heart attacks were the ones who smoked, had diabetes, had more bad cholesterol to good cholesterol ratio. ApoB to A is the bad cholesterol to good cholesterol ratio. They had more hypertension. They had more abdominal obesity, not generally overweight or obese, but obesity that is primarily in the region of your abdomen, and those people who had psychological stress. Whereas those people who ate lots of fruits and vegetables or who were physically active did not seem to get their heart attack. So there was protective mechanism in the system. So we have now learned about those risk factors, which are not modifiable. As you age, males get it more. You have a family history, you have a higher genetic predisposition, but bad lifestyle is the major contribution to you developing the so-called modifiable risk factors, for which you often then need medications. And you can't control them fully or properly with then just managing with lifestyle change. The next thing we've learned about risk factors from many decades ago is that if you have 2 or 3 risk factors, they work exponentially. And so 3 risk factors doesn't mean you have 3 times the risk, but it means that you have an exponentially higher risk level with increasing number of risk factors. The earlier you try to control the risk factors, or earlier you develop the risk factors, more problem you get. So we are looking here at the reduction in risk by a 10% reduction in cholesterol. So if you reduce your cholesterol at the age of 70 by 10% by improving your diet or with medication, you decrease your cardiovascular risk by 20%. But if you decrease your cholesterol by the same 10% at the age of 40, you get an over 50% reduction in your risk of coronary heart disease or mortality. So earlier you start, the better it is. This is an experiment of nature. So this line shows the statins. If you decrease your cholesterol by 20% or 30% with the use of statins over a 5-year period, you decrease your risk of coronary heart disease by about 20 to 30%. All right? But if you have a genetic mutation where you make less cholesterol in your body, and these are various genetic mutations, so for the same 10 or 15% reduction, where if you did it with lifestyle and statins in adult age, you may get a 15 or 20% reduction. Now you get a 50% reduction because now you have a lifetime of 10% lower cholesterol. And if you have a 30% reduction with this gene mutation, then you have almost no likelihood of getting coronary heart disease. So we have the lifestyle-related factors, which cause the modifiable risk factors, and they lead to the development of heart disease. What happens if you already have heart disease with these risk factors? They cause an additional problem if you already. So smokers who get heart attacks have an increasing mortality over time. But if you are a non-smoker, you can decrease that risk. If you quit, you can decrease that risk. So risk factors are critically important after you have a risk factors. This is what we call secondary prevention. It's the same with diabetes. If you control your diabetes better, and so you have a lower mortality. Same with physical activity. If you are physically active, you have a better survival after a heart attack, whereas if you are inactive, you have a much lower survival. Same goes for mental state. The mental state has an incredibly strong relationship and an impact on your survival from cardiovascular disease, whether it is depression on one hand or whether it is happiness at the other hand, which improves survival. So here is depressed people after a heart attack. Here are non-depressed people after the same heart attack survive better. So if you have very poor health behaviors or no good health behaviors, and you don't control your major risk factors of blood pressure or cholesterol, you have a very high mortality. If you have good lifestyle measures and control your blood pressure or your cholesterol well, you will have a much lower mortality. And that is due to partly lifestyle improvement and partly due to the therapies that we have now developed in cardiovascular disease. So risk factors are non-modifiable or lifestyle related, and some are modifiable, for which you often need medication. If you have a combination of risk factors, it's a vicious problem, and it exponentially increases your risk. Earlier changes in lifestyle measures or in risk factors bring you great benefits. Later in life, you need much more aggressive management with medications to achieve the same benefit. So primary prevention is when you use lifestyle measures and sometimes medications to prevent the disease, the heart attacks or strokes from occurring. That's primary prevention. But if you already have a heart attack or stroke, then you are in the field of secondary prevention. And it is even more critical then to control your risk factors and requires intense therapy, both with lifestyle and lifesavers. So I'm going to introduce you to now this concept of lifesavers and lifestyle, which I have been using throughout my career in my practice, explaining that to my patients. So lifesavers are all the things that your physician or cardiologist does, the medications, the angioplasty or the surgery, or whatever management measures your cardiologist institutes to improve your survival and quality of life. This is primarily the responsibility of the cardiologist. He or she has to know how to diagnose you properly, pick the right medications for the right person, use them at the right time, and use the devices or the surgeries at the right time. Whereas lifestyle is the primary responsibility of the individual. You are responsible for your lifestyle. The cardiologist can guide you, but this is primarily your lifestyle. So if your cardiologist doesn't give you the right treatment or does the wrong procedure, your outcome is going to be bad and you're not going to do very well. On the other hand, if you don't follow the program and don't improve your lifestyle or control your risk factors or don't take your medications regularly, you are going to have a poor outcome. It is only when the cardiologist does the things right at the right time and you follow the program and take your medications that you have a successful outcome for the long term. So it is a combined relationship of lifesavers with medications, angioplasty or surgery, and lifestyle, which is a situation with the patient. So I'm going to now introduce you to a concept of what I call protections that are built in nature. When the Lord or whoever looked at mankind and looked at Adam, and he realized right on from that time that mankind or men are going to be tempted by transgressions. They're going to do the wrong things. So let me put in nature things that are going to protect them. So just as there are things that you do that can harm you, nature has developed things in there that are protective to you. And what are those protections that nature has built in? And you'll be surprised when I tell you what the first protection and probably the most important protection that nature has put in for you. And that comes from the surah in the Quran, which says, O mankind, fear your Lord, who created you from a single soul, and out of it, it created its mate. And out of the two spread many men and women, partners and community. Partners and community are the most protective factors towards a long survival, which is also healthy and happy. The Harvard study, which many of you have heard of, which has been going on for 80 years, has followed people over this period of time and has clearly shown that people who embrace community, participate in groups, have good partners who share their love and share their trials and tribulations with them, are more important than even genes. Good genes are nice, but happiness is much better in providing successful, healthy survival. This is a situation where if you have a good, satisfying relationship at the age of 50, you will have a healthy lifestyle at the age of 80, healthy and happy. So not that you're just going to survive, you're going to survive healthier. And it's all about relationships. And the commonest and the longest relationships you have is with your spouse, obviously. But it can be other partners, co-workers, or other family members. So loneliness kills is as powerful a bad risk factor as smoking or alcoholism. So when the study began, nobody really knew that it was going to be relationships that was the major determinant of successful, healthy survival. It was a surprising finding, what the director of that program has said, and a powerful influence on our health. So taking care of your body is important, but tending to your relationship is a very important self-care measure and a revelation that we learned from this Harvard study. So in 2021, just last month, was this major publication that the head is connected to the heart, surprise, surprise, and can have a major influence on your health. So in that scientific statement, they showed this data. You don't have to really worry about this, all the information on this slide, but it doesn't matter whether it is all forms of stress or whether it is depression or it is isolation, loneliness, or if you are a pessimistic person, your risk of dying or having coronary heart disease is significantly higher than if you did not have those factors. Same goes for anxiety, anger, and hostility. So those factors kill you. And if you control them or do not have those factors, you have a better survival. So I have developed this thing, which I deal with my patients, what I call happiness index. On one end of the spectrum is gratitude or a feeling of happiness, good relationships. And the other hand is a pessimistic person who is lonely, who complains, is not grateful for what he has, and has a degree of unhappiness and a state of mind. And this happiness index of 1 to 10 is what I determine in every one of my patients and try and get them to move on the scale towards 10 as much as possible. And relationships play a very strong role in that. Okay, what's the second protection that nature has put into the world that is there for our protection? If you look at mankind, if you look at humans, half of their body is used for their brain, their thinking, all their senses, their heart, their cardiovascular function, their lungs, their kidneys, their digestion, use of their arms. But nature has used half of your body for only one purpose, and that's activity and movement. You have never seen a fat giraffe, have you? But you always see fat pigs because only 10% of their body is legs. So we are not using what nature has given us and used our body. 50% of our body is there for movement. And if we don't move, we get into trouble. So here are people who are physically active. So the inactive people, whether you are quote unquote healthy or not, you have a higher mortality if you become inactive versus if you are active. This is a study of 130,000 people done in multiple countries, clearly showing that whether you look at cardiovascular disease or you look at mortality, those who are physically active versus not physically active have better survival. Physical activity decreases cardiovascular disease, decreases mortality. And you can see it in these graphs. The physically active people with cardiac disease have better survival than people who are inactive. Even after you have a heart attack, even a light amount of physical activity improves your survival. And you don't have to do a large amount of activity. You don't get any further benefit. It is just enough to do a light amount of activity on a regular basis. So there is an experiment of nature going on presently in East Africa. And the Maasai, who have a diet that is essentially consisting of meat, blood, and milk together, which they use, and do not get cardiovascular disease. They have the highest fat cholesterol diet and do not get cardiovascular disease because activity protects them. We are now seeing a change where the Maasai are using motorcycles, they are beginning to smoke, they are gaining weight, they are eating processed food, and you will see this epidemiological experiment of nature show the dramatic and exponential increase in cardiovascular disease that's going to occur in Maasais and other Africans in the sub-Saharan area. What is the third protection that nature has put in our system? And that is fruits and vegetables. There are foods out there that are protective. So if you eat a biryani and have a dessert of multiple fresh fruits after, versus if you eat the same biryani and have gulab jambu or no dessert at all, the person who eats the fruit after that same biryani is going to be protected, more protected than the other two who eat gulab jambu for dessert or no dessert at all. So fruits and vegetables provide a protection. And we know that from scientific data. The more fruits and vegetables you eat, better your survival, less the mortality, and less cardiovascular disease. The other protection is in legumes and grains. And the more you eat of legumes and grains, less your mortality and less cardiovascular disease. So we move on to the situation. We know the protections are relationships, activity, and certain foods. So what can you do about it? Where do you get the biggest bang for your buck? You have to start early in life. Early in life, habits are easy to change. You need to make relatively small changes to get large benefits over the lifetime. Children are more flexible and adaptable. They don't miss something that they've never had before. So you have to keep them away from the bad habits or bad foods. So over the last 2 decades, I've developed a program, and many of you have heard me give this talk or have seen my pamphlets or have been my patients, and I've talked to you about my program of what I call 00530. Zero smoking, zero alcohol, or as little as possible, and I'm not going to go into the details of this issue today. As much fruit and vegetables as you can have, at least 5 servings. 1 serving is what you can hold in your fist. So that's 1 serving. And that is 5 servings of fruits and vegetables. So it doesn't have to be 5 servings of fruit or 5 servings of vegetables, and 30 minutes of exercise every day. This is the program I've developed over the last 20 years. I modified it by adding color and speed to make it easier for everybody to follow. So what do I mean by color or speed? I can go to Hunza and teach this program to a 70-year-old lady who has no understanding of or does not speak English, or to a 25-year-old professional at Stanford. It is all about the color. So when you are looking at fruits, vegetables, grains, or legumes or nuts, just look at them. If they are more colorful, or if they are darker in color, they are healthier. If they are lighter in color, or if they are less colorful, they are going to be not as healthy, period. And the other extreme is foods that are white, processed foods, rice, bread, potatoes, pasta, noodles, rice, bread, potatoes, pasta, noodles, rice, bread, potatoes, pasta, noodles. Those are the starch containing foods that one molecule makes 6 molecules of sugar, glucose, in your system. So more color, healthier. Less color, less healthy, period. That's all you need to know. You don't go to a dietitian. You don't read ingredients. You don't have to go any class. You don't have to pay any money to go through any program. Now, what about when it comes to meats, poultry, and seafood? Here, the issue is of speed. So if you're going to eat a meat, you think to yourself, how fast does that animal move? How fast does that fish swim or seafood swim? How fast does that poultry or bird fly? So, deer meat is better than pig because they just sit around and not do hardly any activity. So all you have to do is think about the meat that you're going to eat. When you look at seafood, the surface swimmers, salmon, trout, sea bass, tuna, are much better because they swim faster. Whereas the bottom feeders are much slower moving, and that fish is not as good as the fish from the surface swimmers. If the seafood is very sluggish, then they have less healthy protective mechanism in them compared to the fish that swim. So yes, you can eat prawns and stuff, but you have got to realize that salmon is better than prawns. So all you have to do is look at how fast something moves. And if they move faster, for example, poultry, chicken, that is farm chicken versus free range chicken that is not in a cage all its life is going to be better. Free range eggs are going to be better than eggs from the poultry where the chicken has been in a cage all its life. So it's about color and speed, and you don't need to go to a diet class. So there are healthy fats that nature has put in our system. And these are olives, canola oil, avocado, and nuts. And these are not as bad. So the monounsaturated fats are healthy, and you can take more of them, and it provides you protection. What you have to avoid is food that is adulterated. So if food is in its natural state, it is going to be not harmful to you. That includes meats. If they are not cooked in oil and they are not fried or they are not cooked in a manner that they are adulterated, they do not harm you. So when we adulterate food by processing them, they become less and less healthy. And particularly if we fry them, it's the hot oil or oil used multiple times for cooking, deep frying, is absolute poison to your arteries. So anything that comes out of a packet or can, or you fry it, or you adulterate the food, it's not going to be good for you. And avoid the empty calories, rice, bread, potatoes, pasta, noodles, starch, and the sugars. Eggs are not bad for you. It's the fried eggs, it's the oil, the frying that is the harmful part, not the egg. Boiled eggs are good and actually healthy. So, exercise, you have to include many strategies in it, most of which are to be taking pride in it, be good to yourself, start slowly, increase gradually. You may need groups to do that. You have to incorporate the activity into your daily life. Park a little bit farther in the parking lot, and you get your 200 extra meters of walking back and forth when you get back to your car, and nobody dings your car door because you're not parked in a tight spot. So there are many advantages, and you incorporate the activity into your lifestyle. So this is my program 00530. So was I right to have taught this program and asked my patients to follow this over the last 2 decades? Well, they did a study of 218,000 people in 50 countries, combining the data from the PURE trial, On Target, Transcend, Interheart, and Interstroke, and published that and presented it at the European Society of Congress Cardiology in 2018. What did they show? You may think these are my slides. Sugary drinks, sugar in desserts and baked goods, fried chips and things that have trans fats, cooked flour with syrup, and the white foods. Isn't this my 00530 program with the same type of slides of fruits and vegetables, legumes? Dairy is good for you when you adulterate the dairy and process it. The deeply processed cheese, the ice cream, the whipping cream, that's what hurts you, not the milk, not the buttermilk, the chash, homemade buttermilk, doesn't hurt you. The meats. And red meat does not hurt you if you don't have too much fat in it and how you cook it. If you broil or barbecue it, there is no problem. So, did they show that this program works? They showed that people who followed this diet, sorry, somebody's talking. Anyway, they showed that they had a much lower mortality and proved that this 00530 program actually works. So their conclusions was the pure healthy diet, which comprises of fruits, vegetables, nuts, legumes, fish, dairy, and meats, and dairy, and eggs, causes lower mortality and also lower cardiovascular disease. And they say that the guidelines will have to change to the 00530 program. And they say that you have 150 minutes of activity a week. So I say 30 minutes of activity a day. So if you miss a couple of days on the weekend or a particular day, so if you do it for 5 days, that's 150 minutes of activity a week. So what is your responsibility? Now I'm going to talk to you about a different concept, not primary prevention, not secondary prevention, but I'm going to talk to you about a different concept, which you may have heard of, but which is the most important responsibility you have towards your children and your grandchildren. And what is that concept? Primary prevention is when you have risk factors to control them so you don't get coronary disease. Secondary prevention is if you get the disease, you don't want to have trouble again or die from it, so you control the risk factors even more intensely. What I'm talking to you about is the concept of primordial prevention. This is a situation where you don't develop the risk factors in the first place. So, this is my program, which I call Successful Survival, which is a long, healthy, good quality of life without disability or dependency. And in order to have that, you have to master the letter S. You have to understand the secrets, that are in the letter S, which are essentially simple and thus very successful. So what are the secrets in the letter S? Obviously, no smoking. So don't start to begin with. And for those who have been unfortunate to start, we have now many methods that we can help increase the quit rate, the rate at how many patients can quit smoking. So no smoking. That's sedentary. Don't be sedentary. Use the half of your body that is there for you to move, not to sit, not to just be sedentary. As soon as you sit for more than an hour at a time, the risk starts to rise of cardiovascular disease. So you should train yourself to sit, work at your desk or whatever, but get up every hour or two, walk around for 5 minutes, answer the phone call. As the phone rings, you pick up the phone, you get up, walk around when you are talking on the phone, work standing with the raised desk. When you're watching TV, walk around while the sports is going on or the news, use a stationary bike, do brain yoga squats, which, by the way, are very effective for maintaining your mental capacity and decreasing the risk of dementia. And basically remain active and incorporate the activity into your daily life. And if your children and your grandchildren do that, that is highly effective. So what do you have to know about the secrets in the letter S about eating? The first thing is eat slowly. The slower you eat, the less you're going to eat, because your satiety center will go into action if you give it enough time, and it will tell you enough. You need to not eat anymore. And the one trick is to put down your fork or your spoon between bites. So you have a bite, you put the fork or the spoon down. Try it. It's extremely difficult, but you have to train yourself. That gives you time to enjoy the food in your mouth and slows down the process of eating, prevents the food from all getting in there together, dilating your stomach, so you end up eating more and more, and preventing the satiety center from going into action and telling you that you're overeating. So slow down. And socializing during meals is another very good way. And I understand the Prophet used to say that you should never eat alone, or he never ate alone. Eat sequentially. So if you have multiple dishes, pick the foods that are healthiest first. Don't load your plate with everything at the same time. Just eat sequentially. Eat the foods that are healthy, then go eat something else next, something else. And the thing that was a real treat to you, the samosa or the biryani or whatever it was, leave it to the last. So you have to go to the buffet table multiple times, or you have to serve yourself multiple times on the dining table. So you are less likely to continue the sequential eating process, or you're going to eat much less of the unhealthy food towards the end. You leave it as a treat after having eaten the healthier food. Don't load your plate with all the food at the same time. Eat sequentially. Supper. The latest time you should have your last meal of the day is before 6 or 7 p.m., ideally around 5 p.m. And if you are hungry or something, you can have a late snack in later on at night, fruits with a little bit of yogurt ice cream or nuts later on. So, early supper. Separate your dessert from your supper or your dinner. People have the dinner, they're still at the dining table, and dessert is served right away, and you have the dessert right away. It's a killer. So you separate the dessert from your dinner, and you eat it later, or you then don't necessarily eat it, or you have fresh fruit. So separate your dessert. Eat small meals and say to yourself, I'm going to serve myself. I'm not going to let somebody else serve my plate. This is the major problem of eating out. Somebody else serves your plate and brings it to you. You have paid for it, or then you think you have to eat it all, or you remember what your grandmother told you, that you shouldn't leave food, in your plate. You should eat all your food because there are people kids in Africa or Asia who do not have enough food. Explain to me how you stuffing yourself with everything in your plate is going to help that hungry child in Africa. It's not. So serve yourself, put half or three quarters of what you think you want to eat, and you will find that it is adequate if you have eaten sequentially and slowly. And your stomach then starts to shrink. And over a period of time, your meals become smaller without you feeling hungry. How you cook your food is more important. So, how and when you eat and the habits of eating, to me, are as important or probably more important than what you eat. I have not told you how to change your diet at all here. I've just told you how and when to eat and the habits of eating. So, what to eat? The secret in the letter S is sugars. Sugary drinks. Baked goods are a very large source of sugar. So, sugar is the new smoking. So, it's not directly sugar that you put in your tea. So, you can put half a teaspoon of sugar in your tea or 1 teaspoon, but don't eat the pastry. Don't eat the croissant. That's the killer. Don't drink the juice, fruit juice. Eat the fruit. All right? And even if you are diabetic, fruits are good for you. Avoid the starch. It is just empty calories. 1 molecule of starch makes 6 molecules of sugar in your body. So you might as well be having 2 chocolate bars. Rice, bread, potatoes, pasta, noodles. Rice, bread, potatoes, pasta, noodles. Empty starch is a killer. And remember speed and color. It's all about thinking of the meat that you're going to eat, how fast that fish or that animal or that or that poultry flew, and it's the color. All the phytochemicals and the flavonoids and the antioxidants are in the color. The Lord has made it easy for you. Colorful things are protective. This is why a red rose is better than a white rose. All right, now we come to the mind, which is an extremely strong part of health. Stress is a killer. Which kind of stress? Stress that is connected with an emotional thing. Working hard at your career, enjoying your accomplishments, working hard to prepare this talk over the last 6 weeks is not the stress that has killed me or will kill me. But if during the process somebody close to me makes my life painful, then that stress with the emotion attached to it is a killer. If I'm competing with my coworkers for the job or a next promotion, that is a painful stress. But if I am the manager or the owner and I can set my work hours and decide when I'm going to go off and what I'm going to do today and what I'm not going to do, you can do a lot and not be stressed and not be harmful. Or if you are an hourly worker, union or whatever, you just do your work and go home, then that work is not stressful. Silence, the secret of silence. It's not about not speaking, it's about the silence of the mind. Learn to silence your mind. Whether you do it in a traditional or a programmed way with meditation or so, or just the fact of putting your mind at rest, walking in nature, whether it is in the forest or at the beach, put your mind at rest and be as close to nature as possible. The secret of sleep. Sleep deprivation is as bad a risk factor as smoking. You need at least 7 hours of sleep, but it's not just the quantity of sleep, it's the quality of sleep. 7 hours between midnight and 7 a.m. is poor quality sleep, And there is a scientific reason and evidence for it as to what happens with your circadian rhythm after 4 to 5 a.m. in the morning, that this kind of sleep is harmful. But if you go to bed latest at 10 p.m. and you can get up by 5, you have the best quality sleep and you're going to be the most productive through the rest of the day. So it's not just the quantity, but the quality of sleep. So you're going to say to me, well, I'm used to going to bed at 11 or midnight. I'm not going to fall asleep. I go to bed at 10 o'clock. I'm tossing and turning and I'm stressed. I'm not asking you to go to bed at 10 o'clock. If you want to follow my program, just ask yourself, when am I getting up? I'm getting up at 8, or I'm getting up at 10, or I'm getting up at 7. Start getting up an hour earlier. That's where you start. You start with the waking, not with going to sleep. Leave that alone to begin with. Start waking up an hour earlier for a week or 2 weeks, then an hour earlier again, and then an hour earlier again until you get to 5 a.m. You will find that you want to go to sleep by 10 o'clock. It will become automatic. You won't toss and turn in bed. The hour before you fall asleep is critical, the pre-sleep hour. During that hour, you don't want to be watching TV or playing video games or doing things such as that. This is the time you want to spend quality time with your partner, discuss the issues of the day, have good relationships. It's that read. It is that hour before sleep that prepares you for the better quality of sleep. Of sleep. Social, the secret of being a social person. It's all about relationships. It's all about being in groups. Do not break your relationships with someone just because he pissed you off with this or the other, just because he has certain attributes that are not the best, that are his um, negative qualities. You have yours, and people put up with you. So don't break relationships because somebody just has a different opinion than you about something else, or that he says something that hurts your feelings. Get over it. Just maintain those relationships. It's for you. You will be healthier and have a better survival. Isolation is the worst, causes depression. And the best of keeping older people happy, preventing older people from going into depression, preventing the older people from getting lonely, is having them spend time with their grandchildren. Grandchildren and grandparents is the best combination for happiness of both because they have a common enemy, their fathers or mothers. So it's all about happiness index. It's an active process. It doesn't come easy. On one hand is gratitude and love, the two most important emotions or attitudes. And at the worst is loneliness and depression. And we have the Harvard study to prove that. So this is something you should tattoo on your forehead. It should be on every mirror in your house. It should be on the placemats where you eat. It should be on the dash of your car. Basically, what I'm saying, you should completely know this by heart. No smoking, do not be sedentary, do not sit for a long time, eat slowly and sequentially, avoid anything that's white, sugar, or starches, eat everything that's colorful and moves fast. Avoid stress. It's the stress that is associated with emotion that kills you, not the hard work. Hard work doesn't kill you. It's the stress with emotion that kills you. Learn the silence of the mind and be a social individual. Belong to as many groups as you can. Participate with them, particularly relationships with new people, being in groups with activity that you're not an expert of. That makes you develop an attitude of humility. And that is all part of the happiness index. So, American researchers and studies have found that if women sleep long hours, it reduces brain strokes, blood pressure, diabetes, and heart attacks in men. So, this is from the most ancient textbook of medicine that has been documented 2,600 years before Christ. This is published in the Journal of American College of Cardiology, so I presume it is of some validity. Translated, it says, inferior doctors treat the full-blown disease. Mediocre doctors treat the disease before evident. Superior doctors prevent the disease before it occurs. So it's all about prevention. The two heroes in my life that have guided me in medicine is Abu Ali Sina, the father of reawakening of medicine in the way we know it now. He started that in the Middle Ages and wrote the textbook of the Canon of Medicine, which was used as the standard textbook of medicine in Europe for 500 years, more than any book has been used for educational purposes in the world. And William Osler, the great Canadian physician, who was the master, he was the father of clinical medicine, the knowledge and the interaction of the doctor and the patient, not the tests, the ability to decipher by discussion with the patient what is going on and knowing how to examine the patient and figuring out that clinical medicine. William Osler is the father of that. And he taught us that the good physician treats the disease. The great physician treats the patient who has the disease. Thank you very much. I will now take questions and leave it to the moderator.